Good afternoon, everyone. Thanks for joining us. We're going to give it a couple minutes to get everyone in the room here. Good afternoon again, everyone. We'll give it another minute or so to get everyone in the room. Good afternoon again, everyone. We'll give about 30 more seconds here to get everyone in the room. All right. Well, good afternoon, everyone. Thank you again for joining us for our weekly Wednesday webinar series. Today's webinar is on platelet derived factor VIII, a different approach to gene therapy. My name is Brett Spitali, and I'm the Vice President of Advancement here at the National Hemophilia Foundation. At any point during the webinar, if you would like to ask a question, please use the Q&A feature at the bottom of your screen. We have NHF staff members monitoring these questions, which we will pose to our presenters after the presentation. This webinar is being recorded and will be available to the community beginning on Friday, October 29th. Today, we will also be live streaming on our LinkedIn and YouTube channels. I'm joined today by Dr. Mary Eppin and Dr. Lynn Mak. Thanks for taking the time to join us today. We truly appreciate you being here, and I'll turn it over to you to get us started.
All right, great. And thank you for everybody for joining us today. I'm Dr. Lynn Mak, and on behalf of myself and Dr. Eapen, we want to thank NHF for the invitation to speak today. So in terms of first aspect, quick disclosures, wanted to mention that the work that we are reporting on today is supported by a grant from the NHLBI through the NIH that is awarded to Dr. Wilcox and Dr. Eapen. Specific to the presentation today, neither Dr. Eapen or myself have any specific things to disclose. So in terms of objectives of the talk today, I wanted to highlight really the technology that's utilized in this lentiviral-based approach to gene therapy, which is known as platelet. And then to discuss the phase 1 study that's open here in Wisconsin at the Medical College of Wisconsin. And as a hemophilia treater, being involved in the science in hemophilia, having attended the recent NHF State of the Science and other meetings like ISTH, some of what I wanted to do on behalf of my colleagues was to have a platform to be able to present information about this gene therapy approach and answer questions. And I think some of that is because as hematologists participating in some of the AAV-based gene therapy studies, I think we've become kind of more comfortable and familiar with that as a technology. I myself have some of the AAV-based studies open here at our site for our patients. But in some of the more recent meetings, I think there hasn't been a lot of granular detail regarding this study or other lentiviral based approaches. So that's really what we wanted to be able to provide you today. So by way of quick introduction, for those of you that I haven't met, again, my name's Lynn Mak, and I'm the medical director of our Hemophilia Treatment Center here, which is the VIII Comprehensive Center for Bleeding Disorders, or CCBD. I am a hemophilia treater across the lifespan. So I was trained in internal medicine and pediatrics, and then did a pediatric hemonc fellowship with additional training with Dr. Maggie Ragney in Pittsburgh, so that I would be comfortable and competent to care for patients really from the time of birth until kind of as old as they come. And we have a lifespan clinic here on campus. One of the great parts of my job, I think, is the integration of both clinical care and research. And I have experience as a clinical researcher as well as a clinical trialist. And those are things that I bring to the study that we'll provide today. And as outlined, I would be the hemophilia provider on the study and would provide direct hemophilia management to any patient that would be enrolled in the study here on campus. And now I'll have Dr. Eapen introduce herself.
Thank you, Dr. Malec. My name is Mary Eppin. I'm a professor of medicine in the Division of Hematology Oncology at the Medical College of Wisconsin. I'm trained as a clinical scientist. Most of my work has evolved around the use of donors who are not matched siblings for both malignant and non-malignant hematologic diseases. The non-malignant hematologic diseases that I have worked on are severe aplastic anemia and hemoglobinopathy, particularly sickle cell disease. I'm an NIH-funded investigator. I've been interested in clinical trials and have been participating in the NHLBI-funded blood and marrow transplant clinical trials network for about 15 years. I'm also the principal investigator for the clinical trials platform at the Medical College of Wisconsin for the Cure Sickle Cell Initiative, which is funded through the National Heart, Lung, and Blood Institute. And the focus of the clinical trials platform is to facilitate gene therapy and gene editing studies for sickle cell disease. I'm also a practicing physician at the MCW Freighted Hospital System, and I practice as a bone marrow transplant physician. And I will be taking care of the patients enrolled on our study during the process of transplantation or gene therapy. And Dr. Malec will co-manage the hemophilia aspect of their disease. Thank you.
Great, thank you for that. So now diving in a little more specific to the technology and then subsequently the aspects of our clinical trial. So this study really targets hematopoietic stem cells, which are a potentially ideal target for gene therapy. And some of this is related to the aspects of the hematopoietic stem cells, which are cells that live within the bone marrow, so that liquid part within the core of the bone. And that is in part because of these cells' potential to regenerate. Kind of further, what we know as technology with gene therapy has evolved is that we're able to utilize specific promoters in order to target specific kind of lineages or lines of these blood cells. And today's talk will really highlight the novel way that we really target megakaryocytes, so that's what's depicted here on the bottom, which give rise to platelets, which are the smallest of your blood cells that circulate in the bloodstream and are really the most one of the most important aspects of being able to form a healthy blood clot or scab or to stop bleeding. And we'll take you through the technology that really targets in the hemophilia space, utilizing these blood platelets to deliver factor VIII at the site of an injury. And I will mention some of the aspects from some of the studies that have been done really over decades. Here I highlight 5 articles. There's actually many more. You can see that this spans back to 1999. And this really highlights what we call the preclinical development stage. And so preclinical development really means when we use basic science and animal modeling before we are developing a trial that would be utilized in a person. And so these are some of the articles that we would highlight in terms of the preclinical development of the lentiviral mediated platelet derived factor VIII gene therapy known as Platelet. So with the technology that's employed in this study, what happens is we utilize a specific promoter, again, targeting the megakaryocytes, which I'll show in a subsequent slide, to ultimately allow for factor VIII to be produced and stored inside of platelets. And that's what's shown here. So this is a depiction of factor VIII storage in platelet alpha granules from a hemophilia A dog model as kind of a proof of concept. So on the left-hand side, you'll see what is an alpha granule within platelets. And then here in the white arrow is some of the granular factor VIII, and in the pink arrows, some of the highlighted cytoplasmic factor VIII. So really, again, with this technology, we're able to allow factor VIII to be made and stored and then ultimately released when needed in platelets. So in the preclinical hemophilia dog model, and for those of you that may not be aware, the hemophilia dog model has been utilized in many different studies with gene therapy to really be able to provide some important information in terms of how different technologies perform and how different technologies are able to reduce the clinical bleeding that would happen in these dog models. So with transduction and transplant of a canine, so dog-specific CD34 positive cell with the megakaryocyte specific gene promoter controlled lentiviral vector encoding a B domain deleted factor VIII. And I'll mention that a B domain deleted factor VIII is the technology that's utilized in many of our factor VIII concentrates. In this study, this is what resulted in the synthesis of biologically active, so meaning necessary to prevent or to provide a healthy blood clot or achieve hemostasis. So a biologically active factor VIII in platelets. Importantly, this showed long-term improved hemostasis, so reduction of bleeding with this platelet factor VIII gene therapy. And the strategy resulted in the production of platelets that stored this B domain deleted factor VIII for at least 6 years after transplantation. All 3 of the experimental dogs lived to be 11 to 12 years old, noting that this is the normal lifespan for these dogs without hemophilia. And here in this cartoon, I'll highlight what is really the process that would be involved with our study that we will be describing. And Dr. Eapen will go into more specific detail about what this would entail for patients on the study. So as I mentioned in a prior slide, this study uses peripheral blood stem cells through a process initially of mobilization and apheresis, which Dr. Eapen will explain in more detail, and then selection of CD34 positive cells that undergo transduction. The transduction is with, again, this megakaryocytic specific integrin alpha 2B gene promoter, which then would allow for, again, these modified megakaryocytes to ultimately produce platelets that have capacity to secrete, when they're activated, factor VIII really at the site of the wound. So at the site of where we need to be able to control bleeding. And then this slide wanted to just highlight some of the clinical trial validation assays. So what was done ahead of the aspect of enrollment of the first patient on study with human cells and the dose response. And here you can see along the x-axis of this graph, this was the vector copy number, and you can see that increasing. And then what the resultant factor VIII activity levels were at those specific vector copy numbers. So now for the kind of second half of the talk, we'll switch gears to talk about our phase 1 study here at the Medical College of Wisconsin, noting really that the preclinical work that I highlighted suggests that targeting factor VIII to platelets may be a feasible strategy for reducing severe bleeding episodes in humans with hemophilia A. And this is a picture here of our medical campus for those of you that have not been to Wisconsin and maybe think that this is, farmland and whatnot. We actually have a very lovely medical campus that our hospital system sits on, as well as my home institution, the Versity Blood Research Institute. So the highlights of the study, really in summary, again, known as the platelet technology, really as any phase 1 study would be, safety is really the goal of our platelet phase 1 trial. So the goal of our clinical protocol is aimed at treating severe hemophilia A patients to receive maximum benefit with minimum risk. and to maximize the benefit of improved hemostasis, meaning bleeding control, and to reduce risks of harm from pre-transplant conditioning regimens. And Dr. Eapen will explain more about the specifics of what that means. There's 3 basic steps, excuse me, in the clinic and really in the clinical trial. So one would be bone marrow stem cells being collected from patients as an outpatient. Then a patient returning to clinic for approximately 4 weeks at the time of what we call the cell transplant therapy. And then subsequently, just as in any other clinical trial, especially the phase 1 studies, would be for the ongoing monitoring of patients for correction of their hemophilia. So by way of objectives, so these are going to be, what the primary aims of the study are. Our primary objective of the study is to determine the safety of a reduced intensity conditioning therapy, followed by infusion of autologous CD34 positive transduced cells with the lentiviral gene therapy vector, again known as platelet. And to also determine the feasibility of the ex vivo lentiviral gene therapy vector. Secondarily, we will look at the incidence of sustained platelet engraftment of factor VIII 30 days after transplant, and to evaluate the augmentation of hemostasis and tolerance to factor VIII in patients who are refractory to factor VIII therapy due to the presence of inhibitors. And I'll highlight on this just quickly. Some of this is from some of the preclinical work that demonstrates that potentially, especially in mouse modeling, that utilization of this factor VIII expression through platelets may actually have some impact on lessening inhibitors. That being said, with this being a phase 1 study, this is not something that we yet know the outcomes in people. So I'll finish by going over really the study population who we're including in the study, as well as some of the initial screening aspects. So I'll take you through this list. For those of you that are familiar with clinical trials, we always need to carefully outline the study population, meaning who we would include in the study. And the inclusion criteria would mean all those aspects of a specific patient in terms of the things they would need to have in order to be eligible for the study. So the key inclusion criteria include adult males who are 18 and up. So this is exclusively an adult trial. Patients would have a severe diagnosis of severe hemophilia A, which would be confirmed by both a 1-stage and chromogenic method. That would have a history of inhibitors to factor VIII, and this would include any history of a positive inhibitor. It does not have to be a current positive inhibitor. For patients who use prophylactic therapy, this can be with a factor VIII bypassing agent or a factor VIII mimetic prior to referral. And as Dr. Eapen will outline in a subsequent study, we would plan to continue patients on these therapies until we know that there is engraftment and production of factor VIII in their platelets. So including with emicizumab, even though this has a long half-life, patients would be allowed to continue on this. Or for patients that are treating on demand, so meeting just with bleeding episodes, they would need to have 4 or more bleeds requiring treatment in the prior 6 months. Patients would need to have an adequate bone marrow reserve, so their blood count showing an absolute neutrophil count of at least 1,500, a hemoglobin of greater than 9, and platelets greater than 100,000. Have adequate renal or kidney function, as demonstrated by a creatinine clearance greater than 60, adequate liver function with a total bilirubin that is less than 1.5 times the upper limit of normal, AST and ALT that are less than 3 times the upper limit of normal, and no known cirrhosis. They have to be willing to document any bleeding episodes by paper or electronic diary, and then willing to return for planned follow-up during the full duration of the study, which is planned to be 15 years, as is customary in gene therapy studies. And Dr. Eapen will outline some of this more specific follow-up in a later slide. In terms of key exclusion criteria, so again, these would be the criteria that patients cannot have in order to be on study. And these exclusion criteria include that they cannot have undergone attempts at immune tolerance induction or ITI within the past 30 days. They can't be enrolled in another interventional clinical trial within the last 60 days, have a contraindication to some of the mobilization aspects of the study, including use of GCSF and the apheresis procedures that Dr. Eapen will describe. They cannot have medically significant organ dysfunction that would limit how well they would do with the planned procedures, including a low ejection fraction, which is a marker of heart function, as well as lung testing that is significantly decreased compared to what we would expect. They cannot have a coexisting thrombophilia, so that means a condition at which they'd be having an increased risk of having an abnormal blood clot form based on planned screening for our common known thrombophilic conditions, including factor V Leiden, protein C and protein S deficiency, prothrombin gene mutation, and having a D dimer that's greater than 3 times the upper limit of normal when we screen. Patients can't have an active history of invasive malignancy, a known bone marrow disorder. As is with other gene therapies, males have to be willing to use contraception in our study for up to 12 months following treatment. Patients can't have HIV, Hep B, or Hep C with abnormal liver function as described, have known active infections, and have planned surgery during the study period. So I know that was a long list, but wanted to highlight what the important inclusion and exclusion criteria are for the study. And then I'll finish with this slide before turning it over to Dr. Eapen. So this is a flow diagram demonstrating what the pre-enrollment procedures are. And we certainly recognize that patients coming to Wisconsin to enroll in a study can have some barriers. And obviously with the pandemic, logistics of traveling have been difficult for all of us. So we've been very thoughtful in the way that we've tried to approach patients that would be eligible for the study. So first we start with the idea of a virtual pre-screening event. This is where a patient would be referred to our study team and they'd undergo really what we consider a pre-consent meeting that we've done by Zoom with myself and Dr. Eapen, really explaining the aspects of the study. Then if a patient is interested, our study team does an eligibility pre-screening. So this is where they would have access to the medical record and they would go through those important inclusion and exclusion criteria to make sure that a patient appears to be eligible. Next, we would have a patient come in person for the actual consent review. Here, the patient would come to the Medical College of Wisconsin Cancer Center here in Milwaukee and meet with the bone marrow transplant team for the consent review. Then, recognizing some of the importance of enrolling in a phase 1 study, we also have a patient advocate meeting. And here, before signing a consent, but having been explained all the aspects of what the study would involve, we have a potentially interested patient first meet with a patient advocate to ensure that they understand what is expected as part of the study, as well as what their alternatives could be. And then if a patient is interested in moving forward, ultimately we end with the actual consent being signed. And then a patient would undergo the baseline screening test with an estimated approximate 6 tablespoons of blood that we would need for our baseline research studies. And so with that, I will turn it over to Dr. Eapen.
So thank you, Dr. Malec. So I'll take over and this in the subsequent slides very briefly explain what is to be expected in regards to a patient who chooses to provide consent for gene therapy for hemophilia. So the whole core emphasis of a phase 1 study is to ensure that the study can be carried out safely. So to begin with, in order to obtain the cells for genetic manipulation, as Dr. Lynn showed several slides earlier, we have to collect blood, particularly blood that contains the baby cells from the factory in your body that makes blood, which is really the bone marrow. But we begin with 2 blood collections. They're actually called peripheral blood stem cell harvests. What it means is that the cells are collected by apheresis. It's a machine that you're connected to. It's usually done by people in the blood bank, and it's similar to donating platelets if you were a platelet donor. The first collection is really saved for you. In the event that the gene therapy doesn't work, then we can give you back your own cells so that your bone marrow would grow and start functioning normally. The second collection, which is done about 6 to 8 weeks later, is the collection of blood cells that will be sent to the laboratory for manipulating the cells so that your platelets can begin to manufacture factor VIII. So basically, mobilization is a word that you will hear often, and it really means moving the baby blood cells that are manufactured into your bone marrow and into the peripheral blood. The cell doses that we need for the safe collection for the patient and for the genetic manipulation vary. You need a higher dose for the genetic manipulation and a lower dose for the backup or the save cells in case something goes wrong. And the reason the cell dose is different is we know what it takes for a peripheral blood infusion to start regrowing, and this is about all you need, but you need a higher cell dose for the genetic manipulation, and that's why one is 4 and the other is 6. Next slide, please. So the first process begins with the nurses in the blood transfusion clinic really evaluating you, because this is collected from your veins, your peripheral veins. Most people have good venous access and peripheral cannulation is not a problem, but very few, estimated to be less than 10%, may require a central venous access, which means there is a line that has to be placed in by a special group of people. If that were to be the case, Dr. Malec or your hematologist will be consulted for replacement therapy about 30 to 60 minutes before the central line placement. It does not require general anesthesia. It's done by radiologists and interventional radiology, and they are experienced at it. The platelet count we make sure is greater than 50,000 to minimize bleeding risks. Next slide, please. So there are medications that are given so that we can rev up your bone marrow to put out the baby cells into your peripheral blood. There are two drugs that are used. Both are given as an injection under the skin. One is called granulocyte colony stimulating factor, and it's given for 3 days before collection. And the other one is called plerixafor, and it's given the day before collection. The side effects are pretty much similar. Most people talk of a body ache, feeling tired, or redness at the site of the injection. It's more or less akin to having a viral infection or flu-like symptoms, and Tylenol is given for symptomatic relief. The side effects are temporary and they resolve very quickly after the medication is discontinued. But these medications are important because you need your bone marrow to overproduce the baby cells and push them out into the blood, which is where we collect them. Next slide, please. So focusing on the second collection, which is the gene manipulation, we need a basic number of cells. And that's actually 6 times 10 to the power of 6 CD34 cells. These cells are treated in the laboratory and it's specifically engineered for factor VIII production. The cells after that are frozen. They undergo a series of quality control performed for viability, sterility, genetic, and protein production analyses, largely to make sure that it's safe enough to be infused back into the patient. So upon successful completion of the quality control analyses, the patient will come back to clinic, and that's where you begin to condition your body before your cells are infused back into you. We call it transplant conditioning. During that process, you will have a central venous line, and getting the cells back is really very similar to receiving a blood transfusion, except that this is not a blood transfusion. This is a bag with specially manipulated cells. Next slide, please. So this is a schema of what will happen. So I have already talked about GCSF, granulocyte colony stimulating factor, and plerixafor. This is followed by collection. You will get the mobilizing agents, both mobilizing agents before both sets of collections. We try to do the collection in one day, but sometimes you have to do a second day of collection to meet the minimum cell dose requirement. Then it goes to the lab. And once it's deemed, once the genetic manipulation is complete and the product has undergone quality testing, is when it's given back to the patient. So the patient pretty much gets admitted to the hospital 4 to 5 days before the actual infusion of the product. We all have an immune system, and the immune system is intended to protect us. In addition to protecting us, our immune systems also know what is foreign and what is native to your body. So because we're giving you a genetically modified product, it is important to trick your body to suppress the body's immunity, which is why we do what is called a conditioning regimen. A conditioning regimen is basically a combination of drugs, which is given at doses depending on the need. So in this case, you don't really need a very high dose. So the conditioning regimen based on the dog models has shown us that the combination of melphalan and fludarabine works. So melphalan is a chemotherapy agent, as is fludarabine, and their function in this particular setting is really to suppress your immunity. So the chemotherapy drugs are not particularly smart. They don't know how to distinguish between an immune cell and a normal cell that's growing in your body. The doses are very low, so the side effects that you anticipate, such as nausea, vomiting, diarrhea, that you would normally expect with chemotherapy, is incredibly low. The dose of melphalan fludarabine that is used, particularly melphalan, is a dose that is used for patients over the age of 75. Melphalan is a drug that is used to treat a blood cancer called myeloma. It's used at a much higher dose. So the toxicity that you would experience from this chemotherapy regimen is incredibly low. You will get fludarabine for 3 days, and you get melphalan for a day. There is a day of rest, and then you get the product that is infused. I know there's a lot of concern that's been expressed by a number of people because of the adverse events on the Bluebird Bio trial, which is a gene therapy trial for both sickle cell disease and adrenoleukodystrophy. So there are instances where patients have developed a second cancer, and the cancer that has developed is really a myeloid malignancy, which is a blood cancer, acute myeloid leukemia. Melphalan per se does not cause cancer. Melphalan has been used extensively for the treatment of multiple myeloma, and that drug in itself, even at much higher doses, does not cause cancer. The acute myeloid leukemia that has occurred in patients with multiple myeloma has really occurred in the setting when melphalan was given with another drug called lenalidomide. And there are many studies, and it's accepted among the medical community that lenalidomide is the drug that precipitated the occurrence of a myeloid malignancy. And if you look at the transplant literature where second malignancies have been studied extensively after allogeneic transplantation, which has been around for 4 or 5 decades, and it's considered standard of care, there are certain drugs that increase your risk of malignancy. They're largely solid tumors. They are not acute myeloid leukemia or myelodysplastic syndrome, and they come from the use of high-dose radiation and solid tumors from high-dose busulfan, which is an alkylating agent. None of those agents are being used in this particular study. AML and MDS has developed in patients with Hodgkin lymphoma and non-Hodgkin lymphoma, and that's again related to certain chemotherapeutic agents, and that is not melphalan or fludarabine. So the reason I took time to explain this is I just want people to know and be reassured that the doses of chemotherapy that we're using for this particular agent, for this particular trial, first of all, are not drugs implicated in the development of second malignancy, be it a solid tumor or acute myeloid leukemia or myelodysplastic syndrome. Next slide, please. So this is our program. The first picture is the Clinical Cancer Center, and you may ask, why am I coming to the cancer center when I don't have cancer? Logistically, the transplant centers at all of the institutions, certainly in North America, fall within the auspices of a cancer center. So that's where all the patients are seen, regardless of whether they have transplantation for a malignant disease, for a non-malignant disease, or for gene therapy or gene editing for any of the non-malignant diseases. And the picture below is Kathy's house, which is a place that patients can stay if they are not local and they have to travel far away. So during the infusion, which is the genetically modified product, we will watch you very carefully. You will be admitted to the hospital, and you'll have a team of nurses and doctors that will watch over you very carefully. Dr. Malec and her team will take care of all issues related to hemophilia and any questions related to hemophilia. Myself and a team of other doctors that are transplant physicians will largely take care of you and on the transplant floor, and we watch very carefully for things that can potentially go wrong after transplantation. During the actual infusion, it goes with pre-medication, so we don't expect people to react. But there are some people that have breakthrough reactions. You could have a low-grade fever, chills, or a low blood pressure. So when the product is being infused, you're really monitored every 10 to 15 minutes with a nurse in the room to make sure that everything is safe. Plan on being in the hospital for 3 to 4 weeks. That is about the time it is going to take for your bone marrow to recover. And thereafter, depending on whether you are out of state or local or from the state of Wisconsin, there are arrangements that will be made either for you to go home or to stay at Kathy's house or some other accommodation. Next slide, please. So patients with hemophilia, understandably, your concern is bleeding, and what can we do to decrease that risk while you're under the care of the transplant physicians? They will remain on their prophylactic replacement therapy throughout the inpatient stay, and that's really managed by Dr. Malec and her team. They will round and be available for questions, factor replacement, or any questions that the transplant team has, and that will all be under Dr. Malec's guidance. When you receive your fludarabine and melphalan, you're going to drop your counts. That's what it's intended to do, because in addition to attacking the immune cells, all of the blood cells drop. And there's about a period of 14 to 21 days for your cells to recover. So platelets are important. They help with bleeding. We transfuse people with platelets so that their platelet number is greater than 50,000. We'll do platelet checks twice daily when the number is very low, and thereafter drop it to a day. But once you start making your own platelets, we don't check it any more frequently than a week or so. The other thing that people worry about and can experience is a sore mouth. And it's usually symptomatic management. We try to prevent a sore mouth with oral hygiene, which you will be taught as you come into the hospital. For hemophilia patients, if you experience bleeding in the mouth from the mucosal membrane, we really will be guided by mouthwashes and tranexamic acid with help from Dr. Malec's team. Next slide. So engraftment, which is the medical term for your bone marrow cells recovering, takes about 14 to 21 days. Your bone marrow will begin to make cells, the modified cells. The first cells to grow are the white cells, and the second type of cells to grow are the platelets. As your cells come back in, we expect your platelets to begin manufacturing factor VIII. And as part of that, there are a number of tests that will be done in the laboratories to make sure that the experiment worked and that the genetically modified platelets are beginning to grow and to manufacture factor VIII. When the factor VIII level measurements are deemed to be safe, a decision will be made by a hemophilia doctor. If you're in Milwaukee, that would be Dr. Malec, as to the best time to discontinue your hemophilia regimen. The inhibitor titers are also followed, and over the course of time, we expect them to disappear. Next slide, please. So the initial follow-up will be at the cancer center under the care of the bone marrow team. And I would say it's typically around a 3-month period, just to make sure that all of the procedures from the transplant itself has not led to any unwanted complications. It's highly unlikely, but we don't want to take that risk. So because this is a research study, there are a number of visits that are associated for research purposes. They're all paid for by the grant, and there is a mandatory 1 month, 1.5 month, 3, 6, 9, 12, 18, and 24-month visit. After that, between year 2 and 5, it's every 6 months, and then once a year through 15 years after infusion. The 15-year follow-up is a mandate from the Food and Drug Administration. During the entire process, hemophilia care is with Dr. Malec. The only time you will return to the cancer center is for the research-related visits. And how often you see Dr. Malec or your local hematologist really is dependent upon them and your disease and your level of comfort. Next slide, please. So this is our slide acknowledging the entire team that has worked on this trial, both preclinically and in developing the actual clinical trial. Next slide. We have a program manager that oversees this. She's in the Division of Hematology Oncology at the Medical College of Wisconsin. You have her telephone number and her email address. This trial is also registered at clinicaltrials.gov. That's the MCT number where you can look up for information. Although we've tried to be comprehensive and covered as much information as we can on the slides, you may actually want to visit the clinicaltrials.gov website to read the information yourself. So thank you for your attention, and Dr. Malec and I am happy to take questions.
Great. Well, we do have some activity. I think that was you might have sparked some questions here. Very interesting. And the first question that comes in, I'm just going to go through these. They may have been addressed in the presentation as they were coming in a little bit early in mid presentation, but I'll ask, when are you enrolling, or have you begun enrolling already?
Yes, so I can take that. Sorry, Mary. So the study is open to enrollment. And so we are actively screening a patient currently. We are anticipating our first patient if this patient does end up enrolling, but we are, again, actively enrolling. So I think for those of you that would be interested, Ariel, whose information we provided, would be a great point of contact. Otherwise, you could always reach out to either myself or Dr. Eapen.
Another question that comes in. Let me see here. What are the biggest concerns during the follow-up period?
So couple of things. Well, first of all, the switch, the production of factor VIII does not occur instantaneously as your platelets recover. It takes time. Our assumption based on the preclinical data is that this will be completed within the first 3 to 6 months. And then there is the follow-up to make sure that those levels are sustained. We don't ever want to compromise safety. So when you go in with a phase 1 trial, you are in many ways in uncharted territory, and you want to take the absolute minimum risk possible, which is why we have the careful follow-up. It is possible that our study is open to enroll 5 patients. It is possible that the knowledge that we gain from treating 5 patients will help us devise probably less stringent follow-up in a phase 2 study, hopefully at a multi-center setting, or we may uncover things that we thought we had covered, but we didn't really cover, and we may make it more stringent. So the close follow-up is really for patient safety more than anything else. And the biggest concern is monitoring the factor VIII level.
Great. And along those same lines, one of the questions that came in and asked, what would be some of the greatest risks for the patient during this study?
So the risks vary depending on the stage at which you're in. The biggest risk is the gene therapy doesn't work, which means you went through a process and the treatment is a failure. That has not been the case in any of the preclinical studies, and one would continue to hope that that will not be the case in humans. But that is the biggest risk when you undertake such a study, that the gene therapy failed or it was transient and it disappeared from your system. In terms of the other complications, because of the very low toxic regimen that we're using, the very low doses, we really don't expect complications such as a blood infection or any of your organs failing, because the doses that are used are so low that we actually expect people to recover from that. That said, things can go wrong at any time. And in the unlikely event that something did go wrong, which is going to be highly unlikely, I would say less than 0.1% from the transplant procedure, you could have organ failure and you may not recover from that, but that is highly, highly unlikely. So the biggest concern when you undertake a gene therapy or a gene editing process is to ensure that that treatment works and it works lifelong. The anticipation is that if you can get them through the first couple of years, which is why follow-up is more rigorous in the first year, and thereafter it goes down to like twice a year, you're home and dry. But this is uncharted territory, so one really has to watch carefully. And I would say the patients who sign up now would really be considered as pioneers in helping to advance the field of hemophilia.
Yeah, no, that's great. Thank you very much, Dr. Eapen. The next question comes in through the Q&A here, and it says, great presentation, exciting new approach. What are the challenges to apply gene therapy technologies that are non-liver targeted in the pediatric population? Also, any predicted risk for post-treatment need for anti-CMV treatment? And I can repeat that if you need me to.
No, so let me just go. So someone's concerned about cytomegalovirus reactivation. Was that the concern?
Correct. Yeah, or CMV, anti-CMV treatment. Correct, is what it was.
So this is the dose of drugs that we use are not drugs that we routinely offer CMV prophylaxis to. We do that for transplant patients who are being treated with much higher doses. But in addition to routine care, if we have a patient who is cytomegalovirus positive, we can monitor their cytomegalovirus titers to see whether they jump up. That's, however, usually a problem in the allogeneic transplant setting where you get donor cells from someone else, which warrants you to be on immunosuppression, a calcineurin inhibitor or a non-calcineurin inhibitor for at least a year to prevent graft rejection and graft versus host disease. It is not a problem. CMV reactivation is not a problem that's typically associated when you get your own cells back, which is the situation here.
Great.
Great. That was a very generic answer, but if the person who asked the question has something more specific, I can address that.
Great. Thank you, Dr. Eapen. Next question that comes in, can you speak more about the potential toxicities of the conditioning regimen needed to complete the stem cell transplant?
Yeah, so this is like the most minimal toxicity regimen that one can possibly conceive. It does not include total body radiation, and the dose of melphalan that is used is a very, very low. So transplant regimen, autologous and allogeneic, is a spectrum. On one end of the spectrum, you have what we call the most intense and the myeloablative regimen. And at the other end of the spectrum, you have the non-myeloablative regimen, where you have some manipulation of your immune system, but it doesn't completely knock it because that particular disease or indication does not require that. So the dose of melphalan that is used falls into the lowest intensity category. So the toxicity from that is expected to be minimal. When you're in the hospital and as your marrow drops its counts, you may have side effects like some nausea or feeling of nausea with or without vomiting, which is treated symptomatically with Zofran. You may have a sore mouth, which is again symptomatically treated. Some diarrhea. All of those are transient and will go away as your counts come back in. The doses that we're using are not expected to have long-term organ damage because the doses are so low. And you can ask why the doses are so low, because you're really getting your own cells back with a degree of genetic manipulation. These are not cells taken from someone else who is a tissue match or a half tissue match, which is what is typically used in the setting of hematopoietic transplantation. So any side effects should be extremely low. And I spent some time addressing second malignancy, second cancer, after the use of melphalan, and it's really not reported in the literature to be associated with melphalan at any dose.
Thanks, Dr. Eapen. Another question that comes in. Can this model of treatment be applied to other blood disorders, such as ultra-rare bleeding disorders or platelet disorders like Glanzmann thrombocythemia?
Do you want to take that, Dr. Malec?
Sure. Yeah, and and I'll mention that the current phase 1 study is obviously just specific to hemophilia, but Dr. Wilcox, who's the basic scientist that's on the NHLBI grant and really who has been integral in the development of this technology, he's very engaged with the Glanzmann's community, and certainly that is the hope, is that that this similar technology would be able to be utilized. So a lentiviral based technology would be able to be used in other diagnoses like Glanzmann. So I think more to come on that, but that certainly is the hope with this really serving as kind of the backbone trial.
A couple more questions that have come in. If such a treatment proves safe and effective and achieves regulatory approval, do you have an estimate of the possible cost of the procedure?
That's an excellent question. That several other diseases for which gene therapy has been in existence for many years is still trying to grapple with. I think the honest answer is no. It is going to depend on what would be considered standard of care, in which case it's covered by your insurance. But certainly the first series of studies, the phase 1s and the phase 2, would generally have to be supported either through an NIH grant, where the grant covers all of the treatment costs, or sometimes it gets picked up by industry, in which case industry covers the cost. So it's going to take some time for people to figure out. Gene therapy has been an option for immunodeficiency diseases for several years now, and it is also open for both thalassemia major and sickle cell disease. And it's all still either being covered through grants or covered entirely sponsored on industry-sponsored trials. So that's many, many years down in the making. So unfortunately, we don't have an answer to that. But I can assure you that should anyone choose to enroll on this trial, the grant will cover the costs.
Great. Thanks, Dr. Eapen. There's a question that came in through the Q&A. It seems there's a lot to unpack here, so I'm gonna read through it, and then maybe we can take it one question at a time, because there seems to be a few questions in here. If factor VIII is stored in alpha granules, what is the mechanism by which it is released into plasma?
Do you want to take that, Lynn, because you're the hemophilia doc?
Yeah, I think specifics of the mechanism, I don't know that I'm able to answer that specifically, but it would really be at the time of platelet activation and release within the alpha granules. So I think it's meant in the preclinical models that at the site of injury, when you would have platelet activation and then release, it would be through the similar mechanisms. But I don't know that I'm able to answer that kind of more kind of granularly. That's probably pun maybe not intended than that.
Well, the second part to that, Lynn, and this might help, well, it might make it more confusing, I don't know, but I'll ask, is will platelet activation by VWF be enough to release factor VIII, and how will you measure peaks and troughs?
Yeah, that certainly is what looks to be the case within the preclinical modeling. But again, that's why we're doing the study, to really look at that aspect of hemostatic control in the setting of bleeds. That's why patients would be followed for the longevity that they are for the study, and be required to provide great kind of bleed and bleed treatment data, so that we have significant information about the hemostatic efficacy of the therapy. And then tell me the second part of the question again. I apologize.
No, that's okay. Let me find it here. It said, will platelet activation by VWF be enough to release factor VIII, and how will you measure the peaks and troughs?
Yeah, so I think I don't know that we necessarily will be measuring necessarily peaks or troughs in the same way that we would be measuring peaks and troughs when we're using an actual factor concentrate therapy. So I think that probably is where some of that question comes from, where as a hemophilia treater, maybe very used to doing sequential factor VIII sampling. So I think this would be more that we are looking at evidence that the platelets, continue to produce factor VIII, but not necessarily aspects of peaks and troughs at the time of a bleeding event.
Great. Thanks, Dr. Malec. I'm going to try to sneak one more question here. This is just a follow because we're at the top of the hour, but this is a follow-up to the cost question. The question came up: how much does a stem cell transplant cost?
An autologous stem cell transplant?
Correct.
It's going to vary from hospital to hospital because it's such a common procedure that most hospitals have negotiated rates with insurance companies, and it is the negotiated rate that is applied. It's covered by insurance, and if you don't have private insurance, it's covered by the state or Medicare. So it's really hard. For the purposes of this study, everything is covered by the grant. It gets billed to the grant.
Great. I'm gonna end on a good question here, I think, and I'll ask both of you this: if the study is successful, what would be the next steps for you?
It would be a phase 2. Also, the chain of events is a phase 1 where you demonstrate safety, feasibility, and the secondary objective is the factor VIII monitoring. If that is deemed acceptable to the FDA, then the natural step is a phase 2 study, which, going from an NIH-funded phase 1, I would hope that it would be an NIH-funded phase 2 trial. The phase 2 trials typically enroll anywhere from 20 to 25 patients, and then you will take it off from there.
Yeah, and I might add, because that is absolutely kind of the next steps in terms of clinical trial development. I think, thinking about kind of wide angle lens within hemophilia, I certainly am excited about the technology and what it has the potential to bring to patients, because certainly I know for some of my patients, the capacity to be treated with a therapy that would ultimately free them from the need to continue to utilize any sort of prophylaxis, being a factor VIII concentrate or a non-factor product, is important. Again, maybe not to every one of my patients, but to many of them. So kind of the idea of being prophylaxis free. And so that certainly drives kind of why I'm interested in science and clinical trials and clinical trial development, and specifically excited about this as a therapy.
Well, thank you, Dr. Eapen, Dr. Malec. Thank you so much for taking the time to join us today and present to the community. As you can see, it was a lively discussion and still continues here. If you do have any questions, you can feel free to email them to me, and I can make sure that I get them off to Dr. Malec and Dr. Eapen. My email address is bspitale@hemophilia.org. Please feel free to message me. Thanks again for taking the time to join us, everyone. Please note that this recorded webinar will be available on Friday, October 29th at hemophilia.org under the events tab with all of our archived webinars. You'll also be able to find it archived on our YouTube and LinkedIn video channels as well. Thank you both again so much for taking the time to join us. We appreciate you being here.
Thank you.
Thank you.
Thanks.
Thank you.